Welcome. Today, we're diving into the fascinating world of osseointegration, a process that revolutionized implant dentistry and orthopedics. Osseointegration refers to the direct connection between living bone and the surface of an artificial implant, without any soft tissue in between. This concept has transformed the way we approach dental and orthopedic implants, providing stable and long-lasting solutions for patients. In this video, we'll explore what osseointegration is, how it works, the theories behind it, and why it's so important for successful implants. Let's start by understanding the basic definition and significance of this process. Osseointegration is defined as the apparent direct attachment or connection of bone tissue to an inert alloplastic material, meaning a synthetic implant without any intervening connective tissue. This means that the bone grows right up to the implant surface, creating a stable and rigid bond. The absence of soft tissue, such as scar tissue or ligament fibers, is key to this process. This direct contact can be verified under a microscope, showing no gap or soft tissue layer between the bone and the implant. This unique interface is what gives osseointegrated implants their remarkable stability and longevity. The interface in osseointegration is where the magic happens. Here, the surface of the implant and the host's bone tissue come into direct contact, forming a seamless connection. This is in contrast to other types of integration, where soft tissues might be present between the two surfaces. In osseointegration, the implant becomes a true part of the skeletal system, allowing for efficient load transfer and long-term function. This interface is critical for the success of dental and orthopedic implants, as it ensures the implant remains firmly anchored under functional loads. An osseo-integrated implant is a special type of endosteal implant. These implants are designed with pores or surface features that allow bone cells, osteoblasts, and supporting connective tissue to migrate into them. Over time, the bone grows into these pores, locking the implant in place. This process is especially important in oral implantology, where the goal is to have bone grow right up to the implant surface, ensuring a stable and functional restoration. The absence of any soft tissue layer between the bone and the implant is what sets osseo-integrated implants apart from other types. One of the most compelling aspects of osseointegration is that the direct contact between bone and the implant surface can be verified microscopically. Under the microscope, there are no signs of scar tissue, cartilage, or ligament fibers between the bone and the implant. This microscopic evidence is crucial for confirming true osseointegration and differentiating it from other forms of implant integration, such as fibro-osseous integration, where soft tissues are present. This verification process helps clinicians ensure the long-term success of the implant. It's important to understand how osseointegration differs from fibro-osseous integration. In fibro-osseous integration, soft tissues such as fibers or cells are interposed between the implant and the bone. This type of integration does not provide the same level of stability or long-term success as osseointegration. The presence of soft tissue can lead to micromotion and eventual implant failure. Therefore, achieving direct bone-to-implant contact is the gold standard for implant success. Brånemark's theory of osseointegration is foundational. In the 1950s, Per-Ingvar Brånemark discovered that titanium implants could fuse directly with bone, without any intervening connective tissue. He observed that the titanium oxide layer on the implant surface permanently bonds with the bone, creating a stable and lasting connection. This discovery paved the way for modern dental and orthopedic implants, and Brånemark's principles remain central to implantology today. The key to Brånemark's theory is the unique property of titanium. When titanium is implanted, its surface quickly forms a layer of titanium oxide. This oxide layer is biocompatible and allows bone cells to attach and grow directly onto the implant. Over time, the bone and titanium become inseparable, creating a strong and durable interface. This process is what makes titanium the material of choice for most dental and orthopedic implants. Let's take a closer look at what osseointegration looks like in practice. Over months and years, the connection between the implant and bone becomes stronger and more robust. Histologic sections show bone growing right up to the implant surface, with no soft tissue in between. This process can be compared to the roots of a tree, where the roots anchor firmly into the soil, providing stability and support. The longer the implant is in place, the stronger this connection becomes. In contrast to Brånemark's theory, Weiss proposed the concept of fibro-osseous integration. According to Weiss, a fibro-osseous ligament forms between the implant and the bone, similar to the periodontal ligament found in natural teeth. He argued that collagen fibers at the bone-implant interface play a role in supporting the implant, and that this peri-implant ligament has osteogenic or bone-forming effects. Weiss also advocated for early loading of implants, believing that the ligament could handle functional forces sooner. The main difference between Brånemark's and Weiss's theories lies in the presence or absence of soft tissue at the bone-implant interface. Brånemark emphasized direct bone contact with no intervening tissue, while Weiss described a ligament-like structure similar to the periodontal ligament. Most modern implants aim for osseointegration as described by Brånemark, but understanding both theories helps clinicians appreciate the complexity of the bone-implant relationship. Several factors influence the success of osseointegration. These include the biocompatibility of the implant material, the precision with which the implant fits the prepared site, the use of atraumatic surgical techniques, and allowing for an undisturbed healing phase. Each of these factors plays a crucial role in ensuring that the bone can grow directly onto the implant surface, creating a stable and lasting connection. Osseo-integrated dental implants can be made from a variety of materials, including metals like titanium, ceramics, and polymers. Titanium is the most widely used material due to its excellent biocompatibility and ability to form a strong bond with bone. The choice of material affects not only the integration process, but also the long-term success and durability of the implant. Interestingly, osseointegration does not require 100% contact between the bone and the implant. The key is the stability of the fixation, not the absolute degree of contact seen under the microscope. As long as the implant is rigidly fixed and remains asymptomatic during function, it is considered successfully osseo-integrated. This understanding has shifted the focus from microscopic perfection to clinical stability and function. The process of osseointegration takes time. Initial evidence of integration can be seen after a few weeks, but a more robust connection develops over several months or even years. During this period, the implant becomes increasingly resistant to external shocks and functional loads. However, the process is dynamic, and the interface can be damaged by prolonged adverse stimuli or overload, potentially leading to implant failure. A critical factor in successful osseointegration is the absence of micromotion at the bone-implant interface. Studies have shown that if there is too much movement between the implant and the bone during healing, a fibrous tissue layer forms instead of direct bone contact. This fibrous encapsulation prevents true osseointegration and can lead to implant failure. Therefore, ensuring the implant remains stable and unloaded during the healing phase is essential. Brånemark emphasized that the implant should not be loaded and should be left out of function during the healing period. This undisturbed healing phase allows the bone to grow directly onto the implant surface, ensuring a strong and stable connection. Loading the implant too early can disrupt this process and lead to failure. Patience during this phase is key to long-term implant success. The osseointegration process occurs in several steps. First, woven bone forms in the gap between the implant and the bone. This bone grows rapidly, up to 100 micrometers per day, and has a random orientation of collagen fibers with high cellularity. However, woven bone has low biomechanical strength, so occlusal loads must be carefully controlled during this phase. Over the next 1 to 2 months, woven bone is gradually replaced by lamellar bone, which is stronger and more stable. Woven bone is the first type of bone to form around the implant. It grows quickly in all directions, filling the gap between the implant and the host bone. This bone is characterized by its random collagen fiber orientation and high cellularity, but it is not very strong. During this phase, it's important to avoid excessive loading, as the bone is still developing its strength and stability. After 1 to 2 months, the woven bone is progressively replaced by lamellar bone. Lamellar bone is much stronger and has a regular, organized structure. This transformation is stimulated by functional loading, meaning that as the implant is gradually put into use, the bone adapts and strengthens. After about 1.5 years, the lamellar bone provides a stable and durable foundation for the implant. In summary, osseointegration is the process by which bone forms a direct, stable connection with an implant, without any intervening soft tissue. This process is influenced by material choice, surgical technique, and healing protocols. Understanding osseointegration is essential for clinicians to ensure the long-term success of dental and orthopedic implants. By respecting the biological principles of bone healing and integration, we can provide patients with reliable, functional, and long-lasting implant solutions.